Hi, I'm Charlie Hennekens. I'm the first Sir Richard Dahl Professor and Senior Academic Advisor to the Dean of the new Charles E. Schmidt College of Medicine at Florida Atlantic University in Boca Raton, Florida. And today I gave an invited lecture at the International Academy of Cardiology meetings in Boston, where I spoke on statin utilization in the treatment and prevention of cardiovascular disease, emerging clinical and public health challenges. And this lecture was derived from a manuscript that is in press and will be published within the next month or two in Clinical Lipidology with the same title, and the authorship include myself, Eric Lieberman, Mark Rubenstein, Dave Demetz, and Mark Pfeffer. So the totality of evidence suggests clear benefits of statins in all high-risk patients, defined as those who have suffered a prior occlusive event or are suffering one. And in addition to the high-risk secondary prevention benefits, the current totality of evidence indicates clear benefits in not just high-risk primary prevention, but the benefits seem to extend into low-risk primary prevention. What we found is that there is no level of LDL cholesterol below which further benefits are not demonstrable, and the benefit to risk ratio seems favorable, even those who have a 10-year risk of a first coronary event of 5% or greater. The importance of these findings stems from the fact that in secondary prevention today, perhaps only about a third of patients are treated with evidence-based doses of a statin, and the evidence today suggests that that should be close to 100%. So there are large clinical and public health challenges even among the high-risk patients. In secondary prevention, the challenges are clear and the benefits are clear. The challenge is to get more people treated with evidence-based doses of a statin. Now, optimally, statins should be adjuncts, not alternatives to therapeutic lifestyle changes. But in addition, other therapies such as omega-3 fatty acids, phenofibrates, nicotinic acid, or ezetimibe should only be considered adjuncts, not alternatives to the statins. We have 170,000 patients randomized and treated for over 10 years with clear benefits that exceed the risks, and we need wider utilization of statins as the first-line drug of choice in virtually all patients. In primary prevention, as I said, about 14% of patients are treated. And let's look at the data in the U.S., for example. In the National Center for Health Statistics Health Interview Survey data and Health Examination Survey data, perhaps 40% of patients over age 40 have metabolic syndrome, a constellation of obesity leading to dyslipidemia, hypertension, and insulin resistance leading to diabetes. Thus, there are so many high-risk patients in primary prevention that are untreated. We shouldn't let the perfect be the enemy of the possible. All of these high-risk patients should be treated with statins as adjuncts to therapeutic lifestyle changes. And now the data suggests that even in the lowest risk primary prevention subjects, whose 10-year risk is only 5% or greater, that the benefits of statins are likely to outweigh the risks. But the most important finding from the randomized trials and their meta-analyses is there is no level of LDL below which clinical benefits are not manifested by statin therapy. Thank you very much.